It's coming. Take it. Oh, this is going live. No. All right, Chilam. You wanna? Chalo, aaja. Let's intubate. Dr. Hassan, can you hear us?
Yes, we can.
Okay,
We
morning
can see
everyone.
you, we can hear you. You all look very handsome and beautiful. So let's move.
Well, I hope not too beautiful, Dr. Hassan. This is a young woman that, from my understanding, has had multiple peripancreatic fluid collections in the past, some of which have been treated, and on repeat ultrasound, there's significant improvement in these collections, but now on cross-sectional imaging, I believe it was a contrasted CT scan, they've picked up a lesion in the body of the pancreas with an otherwise normal CA19-9, and they're asking us to take a look with the US and see if there's anything that we need to sample. Okay, so it's exactly like yesterday, just हमने की थी, okay? Slow introduction until you reach the hypopharynx.
How old is the patient, Kambis?
Guess how old is she? 20,
20
early
something.
20s, yeah.
So more like clinical picture suggestive of pancreatitis.
Slow introduction. It sounds like it. Okay, if you don't have to worry about seeing. If you're feeling the posterior wall, okay, good. Then you push through it. Now big wheel up, and slow motions, okay, and there you undulate and slowly introduce it in. Excellent. Okay, slowly introduce it in. Now let your dials go, and now let's just focus on the color that you're looking at. Okay, excellent. So give a little bit of air, big wheel up, and suction all this out. Suction all the liquid out. So one thing that's really important in these cases is just to make sure that the stomach is empty when you start your EUS. That way you don't have to worry about dealing with aspirations. So dip into the fundus. And the fundus tends to be the area that collects the fluid in the left lateral position. So there we are, that's looking good. So now, so come back, just show me, I'll go over the steps with you. 1 second, give me the scope. So the steps again are scope in a neutral position, dials facing up, okay. We're going to slowly introduce it in to make sure we're below the junction, and I put it about 1 centimeter or 2 down. Then I'm going, this is just to approximate and put the transducer up so that we can see echo coupling. You don't want to press too much because that will cause a problem, okay? So just enough for you to be able to see. After that, all you're doing is raising your hand up in this direction, and you start moving towards the hilum of the liver, and beyond that, hanji, and right there you come towards the aorta. So okay, so you do the same thing. And let's move on. Big wheel down. Good. A little more so that you can see everything. And suction the air down. Air is your enemy. Okay? And then slowly keep moving in this direction towards me. So leave this. If you hold this tight, and your emotions on your left hand will not translate to the right hand. Okay, so that's the hilum of the liver, the portal vein. Okay, those are the hepatic veins. You keep turning right. Right. So the reason that happened is because the big wheel was too much, too flexed. Okay, so let's do it again. Go back.
Big vein.
Yeah.
Liver.
Chale. Keep going. Now you should probably pull back just a little. Again, your big wheel may be too rotated right there. Okay, that is the aorta. Now stop over there. Right here. Okay. Now what you want to do, right there, the big black, so don't, if you press it too much, you will slide off the aorta. So just, yeah, keep your wheel steady, okay, don't move your wheel too much. And just kind of do that and move your hand around until you see what you're dealing with. So right here, okay, if I were to put an arrow over here, so where is the cursor? Okay, that's your aorta, okay. Here is the right cruise of the diaphragm. You're looking for something that is exiting here.
Yeah,
So let's look for it, right and left a little bit, right here. Okay, that is your celiac artery. It's coming off the side a little bit. Okay, so now you're following it. That is where it sort of broke up, it trifurcated. Now follow this. That is the celiac artery. So follow this down.
So, follow in which direction?
You follow it down. Okay, so we're going down. That is your vein. Excellent. Right there. Okay, right here. Bas. Hold the scope here. Now that, yeah, right there. Hold your scope. This is the portal vein. If I go up over here, I reach the liver. If I go down over here, this is the superior mesenteric vein. Okay, and what we are trying to do is track this one in this direction. Okay, so turn right. Excellent. Right there. So now this is your splenic artery, your splenic vein. That is your pancreas. And we can tell looking at this pancreas right away that that's the duct of the pancreas, and it seems somewhat attenuated in its volume. So we then sort of scan it to the left. Okay, okay, good, excellent. So that little black line coming down there is the pancreatic duct that's falling in the neck area. Okay, and it normally crosses. Yeah, so now we need to do the opposite. We need to go in that direction towards the spleen. Okay, so we're slowly rotating our scope to the right. At all times, we're trying to keep the splenic vein and artery on the right side of our screen. Okay, and the pancreatic duct immediately below the transducer. So if you realize that if we keep our scope in the same position and we just keep turning, the pancreas will fall behind us, and that's just because the pancreas naturally tracks upward, more towards cephalid, more towards the head as it goes to the spleen. So what we need to do to compensate for that is slowly pull our scope back, and at all times you want to maintain these two vessels on the right side and the pancreatic duct just under your transducer. Okay? So we're going to the right. Excellent. Yeah, it's not, so the way to see it is to try and give your hand a little bit of mobility. So move your hand right and left. Okay? And if I were to, so, and if you keep doing that, keep doing what you were doing, move it right and left there. That is your PD. Okay, so it's very small and attenuated, and it's not as visible as it would be because it seems like there is some fibrosis in the pancreas, but that is roughly what you're looking at. Okay? So we are now torquing our scope right, and we are pulling back slightly as we go along. Okay, here is the left kidney. And we're going to continue moving to the right, and slowly we'll start coming up on the spleen, right there. Excellent. So this is an important shot to have. Okay? So here is your spleen, here is the left kidney, and if you're seeing pancreas between these two, that means there is usually no atrophy. Okay? When there is atrophy, you start seeing less pancreas or no pancreas here. So we're still not done though. You want to continue with the splenic vessels, big wheel down. And you want to put your big wheel down because as we move in this direction, we are getting closer and closer to the fundus of the stomach. So to continue to maintain coupling, we have to keep our big wheel all the way down, and that maintains coupling. So this here is the hilum of the spleen. Okay? This is where splenic vessels enter, and you normally want to track here to look for things like varices or veins that are engorged that might lead to varices. Okay, so now that we are at the hilum,
Yeah, this is the
we slowly want to do the exact opposite, which means we need to release that wheel a little bit. Your wheel is too flexed. Okay, slowly release your wheel. Turn. Release means so you went all the way down, right? So now you need to do the opposite. You need to start going up.
Okay.
And we are turning so little more up. Go up. There's too much down.
Okay.
Up. Okay. Excellent. And there we are. So now you're seeing the pancreas, and we're slowly turning towards the left as we're doing that. Fantastic. Okay. So now you've come over your pancreas. Pancreas is done. Okay. So you tracked the pancreas from the neck of the pancreas. You went all the way to the spleen. You kept these these vessels on the right side, and so you've evaluated the pancreas. One thing to
Dr.
keep.
Kamble,
Yes. Sure.
just a question. Where would you see the adrenal gland in there when you're looking at the kidney?
Right. So to see the adrenal gland, what you normally would do is you find your celiac, okay, which is right here, and you turn to the right, and right there is the adrenal. So go down on your wheel a little bit.
Okay.
Okay, right there. Stop. So excellent. So what you see here is this thing that looks like a seagull, like a bird that is flying. And usually in the same frame you'll see the kidney here as well. So that there is the adrenal gland, or the medulla of the adrenal gland is what you're seeing. The cortex is usually white in color.
Thank you.
So when you see adenomas, or if you need to do RA, which is a newer indication for it, that is where you see it. Okay. These are, yeah, but you're too down on your big down. Okay, you want to stay here. Okay, excellent. So now give me the scope 1 second. Okay, good job. So now what we're doing is I'm just going to quickly scan her pancreas one more time. Okay, just to make sure we're not missing anything. Again. Okay, so this is that lesion that they're talking about. Dr. Shanil, are you able to appreciate this lesion over there? So, if I were to sort of look at an area of the pancreas that appears somewhat different or lobular,
Yes,
it would be this area. Okay? How do you कैसे distance यहाँ पे mark करते हैं? So this area, I can tell you, is not does not look like a tumorous or a neoplastic process at all. How do you? अच्छा एक और कैसे करें? ये वाला. And set. Okay, so we're measuring this lesion in its two largest dimensions, and it's about 11 by 8 millimeters. That's close to what the CT picked up. You know, just by looking at it, we can tell that it's likely to be a result of the pancreatitis and not the cause of it. And the reason I say that is because for a mass lesion to cause pancreatitis, it usually has to be in an area where it is obstructing a significant amount of the pancreatic duct, and in this case it doesn't appear as though that's something that this lesion could do. So if I were to favor something, I would favor sort of an evolving or a necrotic process, or just a lobularity that is residual. So we'll come back to looking at this in a minute after we've evaluated the entire pancreas. So once we're at this station, again, the way to sort of figure out where to go down is to drop your scope. You don't want to go into the fundus, you raise it back up, and then you follow the rugae. You want to follow the rugae all the way down. We continue to introduce the scope down until we see the pylorus, but the key, but the key thing here is not to see the pylorus as you introduce your scope in. Okay? Now, once you've reached this area, the thing to focus on is the apex. That is the apex. Okay, so I'm going to slowly push my scope in towards the apex and suction down. And that typically will reveal structures in the hepatico-duodenal ligament. So I'll tell you in a minute. ठीक है, तो यहाँ पे in this area we are looking at different structures. And this here is the portal vein, this here is the bile duct, and they are stacking up usually. So this is called the stack sign. You don't always see this because of the way the duodenum is, but when you do, it's quite sort of revealing. So again, if you're ever questioning yourself, you don't know what is going on, there's a dark structure, I need to find out what it is, you throw a Doppler on top of it. Okay, so here you see the Doppler is lighting up blood vessels, it's not lighting up the bile duct. So we know that that is a bile duct. Okay? And initially you'll have this, you'll want to, bas Doppler kaise hai? You'll want to sort of make sure that that structures you're looking at are not in fact vessels. Okay? So ye bile duct, we're tracking the bile duct up, and I'm just sort of in my mind thinking what could have caused a 22-year-old's pancreatitis. And the most common cause statistically is gallstones. Guys, is her gallbladder in or out? Gallbladder?
At this side, the pancreas will appear near the transducer, or it will be away from the.
This is all pancreas. Yeah, okay. This is all pancreas. And so the orientation of the pancreas here in the duodenal bulb is in this direction. Here is the tail of the pancreas, that is the head of the pancreas, here is the hilum of the liver, and the ampullary complex is down here. So the tail is down here in the left lower area, the head is up here, the head and uncinate process. Okay? So now our goal is to follow this down to an area where it meets the duodenal wall. So here we are, this is the intrapancreatic portion of the common bile duct, because I see pancreas surrounding it, as opposed to this area where there is no pancreas surrounding it. So this is the suprapancreatic portion. Okay? So we're going to track this down, we're coming down, and we are going to sort of move into an area where this meets a line. Now if you notice, you squint your eyes, you'll see a long line emanating here. And this is the MP of the duodenum, the muscularis propria. So this, when it meets here, that is the ampulla. Okay, right there. So this round thing that is appearing here, that is the ampullary complex, right here. Okay? So we've gone to the ampulla, now we are going to track this back up towards the hilum of the liver and tracking it up. We're going to release our big dial to make sure that we're not compressing inadvertently any problems here, and
Was
that
there a
is
stone
where.
there?
Sorry?
Was there a stone there? Just do the clockwise. Yeah.
Yeah. Was there a stone in the
I think-
bile duct?
Yeah, that one? Or it just looks like that?
No. So I'm looking at it on a different screen, Shanil, to see if I'm missing anything. But no, I'm not
Okay.
seeing any.
I think it's just a projection.
So, okay. So I'm going to track it back one more time by just zooming in to make sure we're not missing anything. And so we're taking extra caution to not compress that bile duct. And this is where it's entering the. So this is where it enters the liver, okay, the bile duct, and branches out, and we're tracking it back down, and yeah, Dr. Shanil, I'm not seeing a stone here,
No, I think it's just a projection here.
just the protection. Okay. So now what we'll do is we've looked at the bulb of the duodenum. I'm just cleaning my lens. And it's always a good habit to put your big wheel up, get a look at where the duodenum is, okay, without blindly pushing, look up, and then push through that area until you comfortably pass your scope down. Small wheel to the right, hold it or fix it, and then you right torque your scope and you reduce it. Okay? We're now trying to visually identify the ampulla, and it's right there. I then put my wheel down to sort of approximate the ampulla so I can see what we're dealing with. You usually have to pull back just a little bit, and all this area here is the uncinate process of the pancreas, right here. This is all uncinate of the pancreas. Okay? So we're tracking it around to make sure. So I see a little bit of sort of nodularity and lymph nodes in the area. It's probably a result of her pancreatitis. That's her bile duct that we're tracing up, and yeah, I'm not seeing anything here. I'm just going to try and track her pancreas all the way from the duodenum up into the stomach. Come. Okay. So let me just get you back. 1 second, hold on. Okay. Come. So we're going to evaluate this one more time. Go down. So big wheel down.
Yeah.
Go push in, push in, push in, push in. Big wheel all the way down because you're pushing there instead of
Yeah.
going there. Take it. So all the way down.
Some gel.
थोड़ा जेल लगा दे. Go ahead. So clean your lines. Go. Push. Slowly, ahiste. So always be slow in what you're doing.
This
Okay?
is the
Now
apex.
this is the apex. Suction
Yeah.
down.
Suction and big wheel towards me.
Big wheel. So
To approximate.
okay. So this. Okay. So here is your portal vein.
Yeah.
Okay, so when I end up in a situation like this where you're not sure what we are looking at, it's always a good habit to just move around a little bit to try and identify a structure that will help you. So we're looking here at the portal vein, right?
Yeah.
So now I think the problem is that we're putting too much
Too much pressure. So it
pressure
pull-ups the
here.
CBD.
Yeah, right there. So that
Oh,
was in
yes.
fact the IVC. Yeah,
Oh.
एक मिनट, so right there, ठीक है? तो ये आपकी portal vein है, and that is the common bile duct. Now you're questioning and saying, भाई, what is this? Am I really looking at the bile duct? Always throw a Doppler on, and you see that the bile duct is not going to light up, ठीक है? So now let us be gentle and big wheel up a little bit.
A little bit.
Up, ulta. And to the left, big wheel up more up, yeah.
Okay.
And up a little more, up a little more, and little more, or you all the way up. So you've come to the liver hilum, okay? Now here, you have very good view of the biliary apparatus as it's entering the liver. So now that's enough. Now we need to go the opposite direction. So we are tracking this down. Okay? The reason you're seeing all this air is because you've not suctioned down. Suction down. There you go. So now we're tracking this bile duct and we're going down. So you're doing the exact opposite of what we just did. Okay? So you're going up on this, suction kijega. If you don't suction, you will not see. Okay? So I'm not sure. So can I just see what your wheels are doing here? Okay, yeah. So reposition yourself. I think we've just okay. Come back out. Okay, go back in now. Go back in. Go back in. Okay, wait there. Suction. Suction. Okay, right here. Okay, that is your GDA, by the way.
Yeah.
This is your gastroduodenal. ये artery है आपके. Okay, that's your GDA coming here, but you need to track this, not that. This.
Yeah.
The good seagull of machine.
Yeah. This.
Now push in a little bit. Excellent. So now your suction. Keep the suction on. So this is your intrapancreatic common bile duct. Excellent, excellent. And you push it down a little more. Big wheel up a little bit.
Okay.
Up. Suction karo. Suction it down.
This is the liver hilum.
This is the hilum, yeah. So that's fine. So let's move down into the second portion. Give that a shot. So you've evaluated the common bile duct from up to down. Take it. Go. Excellent. Small wheel to the right. Fix it with. You like to lock it. It's not a good habit initially. So try to not lock when you start. Okay, अभी इसको free कर दो. Okay, good. Now let's get a look at that ampulla right there. Excellent. Now go up against it. Go up. So always, if you want to do that, the big wheel has to go down. Okay, good. Now here you are. Excellent. Pull back a little bit and always stay dynamic on your hands. Okay, your hands have to keep moving. ये आपकी right kidney है. Okay, so that means you've gone very far out that side. So that is your far out. So you need to pull back right here. Excellent. So right here, hold your scope. Stay steady. Don't move. This is your uncinate process. ठीक है? यहाँ पे focus करनी है because this is going to be where your ampullary complex is. Okay. So there, you see that? That is a common bile duct. So you've got to look at the very lowest part of your common bile duct. That's here. Your pancreatic duct will come from here, and where they meet together on this black area is where your ampulla is. Okay? So very small movements, mini movements, and you're turning right and left, you're evaluating this area. So you don't complete a pancreatic evaluation until you see these vessels. Okay, you have to see the SMA and SMV on one side, and then you have to see your ampulla on the other side. Okay, that is very important. ये पूरी evaluate करनी है. This, if you are not turning all the way down, you are going to miss an uncinate process lesion. So you must not. You must always evaluate that. That is a good. So hold it right here. Don't move. Right here.
Yeah.
So this is muscularis propria of your duodenum. This is all pancreas, and this is your common bile duct here that is meeting this area. So that is your ampulla. Okay, her PD is not dilated, which is why you're not seeing it. So excellent. You've got a good view of the entire pancreas, and I'm going to do this with you just to pull back. Now release your wheels, all of them.
Wheels are
Released. Excellent. Excellent. So that here, that's a little bit of calcification in the pancreas. So if you've noticed, what we've done is from the second portion of the all pancreas, yeah. From the second portion of the duodenum, in one motion, we've been able to come all the way back into the stomach, and we're going to finish a pancreatic evaluation to the tail of the pancreas. यहाँ तक. Big wheel down, big wheel नीचे करो. Fantastic. That's your high limb of the spleen. So in one evaluation, you went from the ampulla all the way back to the spleen. Okay? That is important. Now let me take one quick look over here. Good job. Very nicely done. So, Dr. Shanil, our thought process is that we're looking at this.
मैं आ गया वापस.
ठीक है जी. So, the only thing we're really seeing in her is this little lesion in the tail of the pancreas.
Yes.
That looks like a resolving a collection. The question to us was FNA or not, and our thought process is that this a lesion in the tail of the pancreas that's not in any way compromising the pancreatic duct is very, very unlikely to be the cause of pancreatitis in this patient. And given that and its emergence right now, that it's quite unlikely to be a neoplastic process. And so I favor just following this with cross-sectional imaging to make sure it resolves and not sampling it. What are your thoughts, Dr. Hassan?
I think that is very reasonable. Main thing is, if it was in the head of the pancreas, yes, we would do FNA, because that could be the cause of the pancreatitis. But my only concern is that we don't have a real-time images. You have real-time images over there. Real time in a sense is not projecting very well.
It's not.
My concern, the way it looks like, is it really a collection in the pancreas, or it is a intrapancreatic lymph node, or is it a neuroendocrine tumor? She being young, and if you don't have any other option, it is very, very reasonable to follow in 2 months time, 3 months time with the CT or cross-sectional imaging. If it is still there, then consider FNA.
Hanji, that's an looking at it, she, from her history, she's had multiple collections that seem to be resolving. And, could it be a neuroendocrine tumor? You mean a solid cystic type of neuroendocrine tumor?
Yeah, because there is some cystic changes there.
And
a collection wouldn't be like small collection like this. It would be more like a fluid by now.
More fluid by now, huh? She's recently had these multiple collections that have been drained. I don't know if I mentioned that in her history.
Yeah, you did.
So your thoughts are FNA or
No,
follow?
I think either way is fine. We can do a FNA or we can wait. So whatever you are comfortable with. I think both ways are fine. She's young, but my concern is it a neuroendocrine tumor?
Looking at it, you feel that way, huh?
Yeah, looking at at that from here, and this is what I might do if it was me. I may do a one pass, make a slide, and see what it looks like. If it all looks necrosis, leave it. But if it looks like some tumor, then maybe just do a second pass on it.
Okay, that's not a bad idea. Guys, can we have a 22 gauge acquire, please? And just give her a dose of antibiotics, please. Guys, antibiotics, 22 acquire.
Do you see any role of any contrast agents like Soloview?
That would be very helpful. It's true. If we did have contrast, this is
So,
an ideal case
Kambi's,
for that.
Shanil said, could it be a solid pseudopapillary tumor? So that is a possibility because there's some cystic changes, but it's smaller
Yeah.
in size.
No, but-
It is possible because the outer surface is not as complete round,
Right.
the way usually the neuroendocrine tumor
Right,
is.
right, Dr. Sand. I was going to, it's not also a typical location for a pseudopapillary tumor. Those tend to be in the head area, and they do, Shanil, to your point, affect patients of this age. So that's definitely a consideration.
And usually
Question
they are much
is-
bigger when they
Hanji.
appear.
Question though is it causing the pancreatitis? And that is for a lesion in the tail, very unlikely to be the etiology of it. So we're just going to do a quick pass here to make sure it's not neuro. And अच्छा कोई इसे 1 minute पकड़ ले तो scope को, हाँ, just stabilize it. Doppler लगा दे वहाँ पे जल्दी से. Can barely see it. Okay, कोई ना, इसको B कर दो. इसे यहाँ पे पकड़ लीजिएगा. So we're in the tail area with some degree of respiratory variation, and it tends to be one of those. Yeah, go ahead.
Not typical serous cyst adenoma too, but when you made the image a little bit more bigger,
Yeah.
start seeing some more small cystic changes there.
Yeah. But in these patients with necrosis and sort of a resolving necrotic collection, Dr. Hassan, are there certain clinical points that would prompt you to be more aggressive with doing FNA and working these patients up, or
Yeah, in this case, I think it has been quite some time to the point that they already have drained the other fluid collections, and this is still looking more like a
a
solid.
solid lesion, is
Yeah,
it?
that's what prompted me. If it was all
Yeah.
fluid, I would call it inflammatory process.
अच्छा इसके ना सिर्फ touch imprint आप बना दें. Yeah, the other thing that that makes me sort of wonder, Dr. Hassan, is that it's too small to sort of cause any mass effect on structures around it that a neoplastic lesion would. But is that something that you think about when you're evaluating these lesions? If it is sort of expansile and pushing down on areas around it versus something like a necrotic collection that seems to be resolving, that would not cause mass deviation of structures around it like the PD or vessels.
Yeah,
Is that something that you look for?
Yeah, you always look for that as well. In this case, there's some pancreas beyond this, even though it's close to the tail. Is it enough pancreas beyond that that it's causing a trouble there, and that's leakage of enzymes there?
So someone in the Dr. Saqib mentioned a really interesting point, which is there a role for sono contrast agents in a situation like this? And my impression is this is the perfect case for something like that, where you're trying to distinguish a dead sort of collection of pancreas versus something that is a neoplastic that tends to be more vascular with neuroendocrine lesions. And I would think there's definitely a role. What are your thoughts, Dr. Hassan?
Contrast only works in Europe, nowhere else.
Okay, so there we have it.
So I think to Saqib's point, yeah, this is you're right. It has some role in there, but us Americans who don't use much, we have available in our unit if we need to use it. We have Sanoview, and here and there we use it, but we are not very enthusiastic about that. But you have a point, like it would help differentiate between a tumor versus just a necrosis.
How about elastography
Again, same place. It only works in one place.
in Europe?
In not even for whole Europe, I guess.
Yeah, so we're just taking a quick look, and no pancreatic and sort of evaluation is complete without a good look at the gallbladder. And something to emphasize every time you're looking at the gallbladder is that you should agitate it, because EUS doesn't always give you a good view of all of the areas of the gallbladder, and so agitation is helpful. And we're not seeing anything here that is concerning.
In the antrum of the stomach to look for the gallbladder.
The antrum of the stomach is a good place to look at the fundus of the gallbladder, yeah. So we should evaluate the pancreas once, and we just see what that tissue looks like. And Ajay? Okay, so बना दी. Can I just see the core? मुझे सिर्फ उसकी core दिखा दो. Adequate है कि नहीं? Core दिखा दे एक मिनट.
हम भी slide बना रहे हैं.
We're in the process. I just want to make sure I have enough tissue, and we'll end the case. Okay. Yeah. So can you focus on that, Dr. Hassan? What do you think?
If we can focus on that, I think if you have enough tissue, then we can stop. That's fine. और जब भी FNA करते हैं ना, तो needle जो है, make sure कि it does not touch the duct. ठीक है? Duct से दूर रहना है. Once you puncture the duct, that can lead to really bad pancreatitis. So there's a leakage.
Shall we get done?
Every time, especially with छोटे lesions है, उसमें just make sure that you don't puncture the duct. Stay on the side. If you see a branch duct, that's a problem. Usually you should not see it, but if it's prominent enough, then that means there's some sort of obstruction outside PMF. उसको avoid करना चाहिए. But mainly I'm talking about. Yeah, pancreatitis risk is really, really low. ठीक है? It is very, very safe procedure. ठीक है? It's a there is a very small risk of pancreatitis, but it's not zero. So if you are careful, especially in difficult locations.